Today, with what we have had early in the morning and what we know is happening globally, that ODA backbone is weakening. The US is increasingly, and as long as this administration is there, is increasingly looking inward. The UK, as recent as a few hours ago, has introduced and given a plan on how it's going to cut its aid budget. If you look at the Netherlands, the EU, they are increasingly shifting their priorities to be inward. So as a continent, as a country, we also need to look inward. Some organizations like the World Bank are warning that there'll be a sharp decline in this concessional financing over the next 5 years, 2 to 5 years or so. Gavi, the other day when they are doing the replenishment call, is struggling because it's underfunded. The US pulled out. The Global Fund, US is increasingly looking inward and was the biggest contributor to the WHO also. So as a continent, as a country, we have to look inward also and ask ourselves, what do we do to make sure that in these disruptions, that the financial pain is there, yes, but the disruption is minimal. In Kenya, the consequences, and they have been elaborated, they're very clear. There's reduced funding to community health services, there's disrupted supply chains on HIV, TB, malaria commodities, and there's uncertainty around the vaccine procurement. The other day we were reporting about the vaccine shortages. So these disruptions are where we come in as media, and we need to speak about them. But like I said, we need to advance that conversation and just beyond saying ODA has reduced, these are the gaps, what next? Because the solutions are there. The cost of inaction for a country like ours is very steep. If the ODA continues declining without us looking at alternatives, we risk reversing many, many decades of progress. And I just look back at the last 25 years because that's when Gavi came in, so the issues of vaccination and childhood illnesses were addressed. 25 years ago, the issues of HIV and PEPFAR came in. So we risk reversing those progresses. We risk seeing maternal mortality, which has increasingly been dropping, rising again. Vaccine preventable diseases may return. And we've seen what has happened in the US with vaccine hesitancy and people not vaccinating their children against measles. You're seeing a country like US reporting deaths from measles. And we risk also starting to report that at an increasing levels. So these health systems that people have painstakingly built over the last many decades could falter. But more than the money, this current situation of aid freeze reveals a deeper problem. It reveals our over-reliance on external funding. And I like what Akwale just mentioned it here. That back then, when you go to the ministry to present your budget, like, we need this additional funding, then they're like, talk to your donors. What does that tell you? We have relied a lot on donor funding, but it's about time to think differently, to stop treating development assistance as a permanent solution, but rather we should treat it as a temporary bridge from one place to the other. So what next? And this is to you as members of the Fourth Estate. We need to clearly redefine the role of official development assistance from the lens that we see as media in reporting. It must evolve. Rather than reporting it as something that plugs the funding gaps, we should report it as something that strengthens the capacity for our African health systems. It's supposed to be catalytic, not a substitute for our health systems, for education, for agriculture. So we need to change the narrative. We need to change our reporting from saying we have a funding gap, but look at it as it did this, but what else can we now do now that we are on the other side of the bridge to be catalytic and not a substitute for what should have been allocated or spent from our own internal budgets. Again, we need to move from aid to co-investment. What does that mean? We need to reframe official development assistance as seed funding to spark domestic innovation and investment. It's not something to perpetuate a lifeline of dependency, so that it's a core investment, something that is your capital investment for you to do something and move forward, but not something that we are depending on in perpetuity. We need to discuss and highlight domestic resource mobilization as a country. As African countries, as Kenya, we must step up. The health financing gaps targets, like was said at Abuja Declaration, the 15%, and Dr. Githinji talked about it. We have to move away from that and start seeing, where the funding can come from domestically. We must increase tax efficiency. It's still part of domestic resource mobilization. What Dr. Oronje talked about, reduce leakages and wastages, and we must promote efficiency. With the money that we have, what are we doing about it? We must reprioritize health spending. And it has been touched here, and I hope you can be able to cover this, is what Dr. Githinji really elaborated, where these programs come and you're only covering malaria, you're covering HIV, you're covering TB, but not looking at the person as a whole. What that does is cause inefficiency in the health system. And we've seen that when they pulled out, then you find that you have a weak foundation. So we must report differently and offer solutions, because the solutions are there. The fiscal space is limited, but what are we doing with what is there? You go to, and I will challenge all of you to have a look at this. If you go to the Gavi website, they publish everything. So they did an audit report of Kenya and how Kenya was spending the Gavi funds that come into vaccination. And you'll find that expenditure is not supported. You have drivers that have been sent to pick vaccines, but there are no vaccines that have been picked, and then vehicles have been fueled, they've been given per diem. So you ask yourself, this is donor money that's supposed to go to vaccinating children so that we have zero-dose children, but there are people who are earning per diems, fueling without necessarily fueling, picking vaccines that are not there. So we have to look at those wastages, those leakages, and make sure that we bring them to the fore, because at the end of the day, our job is to hold power accountable. We have to look at the role of local manufacturing. Universal Corporation, just here in Kikuyu, less than 25 kilometers from where we are, is one of 2 pharmaceutical companies that have been pre-qualified by WHO in sub-Saharan Africa to provide medicines. The other day, they were allowed to provide ARVs. They have been providing, I think, family planning commodities. There's malaria, and it's just here. But what does our country do? We import the same medicines that are being produced here. And the challenges that Universal will tell you is that the manufacturing environment is not supportive to what they are doing. The labor costs are increasing. But are we asking our government what they're doing to support an organization like that is globally recognized to procure medicines and send to 19 countries in Africa? But here in our own country, we are not, yet they're just, 25 kilometers from the capital city. Are we asking those questions? Because if we are to use the resources that we have locally, then it goes a long way in bridging the gap that we've seen that has been left when the donors will pull out, and they'll continue pulling out. The fourth thing that we need to think about is new partnerships. From private sector, from local philanthropies, impact investors, all this must be brought to the table. There is untapped potential in public-private partnerships and blended finance models that come with that. So as Africa, we have these ideas, we've heard them this morning. We just need different partners to believe in them. And I dare say those partners are within this continent. We don't need to look beyond where we are. So what then is our role as media? We as journalists, editors, communicators, we have a profound role to play. We must document not only the pain of the withdrawal of the official development assistance, but the opportunities for African-led solutions. And I've given Universal as one of them, and there are many others. We must frame these public debates around equity, around accountability, and around innovation. We at Willow Health Media, we've seen the power of such kind of reporting, the power of powerful journalism. It can shape public policy and perception. When President Trump gave the executive order, we did a special coverage on the US government aid freeze, and you can have a look at it on our website. And we covered it as an evolving story, up to holding a webinar, because we needed to bring different voices into that conversation. We looked at, we called it a vanishing lifeline. Can Kenya's healthcare system survive without US funding? And we looked at the US funding in Kenya since 1950, just to see what that gap would look like. We looked at the Ministry of Health. Out of the 80 billion shillings per year that comes into these funded programs, the US government funding is around 28 billion. So looking at those, our responsibility is to ask, the people, the policymakers, what it is that they are going to do to make sure that, yes, money has been withdrawn, but what are they doing to make sure that the services still continue and that there is no disruption in provision of medicines and the other commodities that people need. And we've seen in certain counties where they have flattened the verticalization of the programs that we've talked about to integrate them into everyday health system provision. And one of them is like Nakuru County, where when clinics were not working because of the funding crisis, they just integrated it into the usual public care or public health care. We looked at vaccine shortages and looking at the last 25 years. So we looked at how the delayed vaccination would have consequences on children, and I've talked about it, and how this is tied to our shrinking global and domestic commitments. We're looking at Kenya's commitment into funding its own vaccination, and Kenya should have taken off by 2030. But when you look at increasingly what we are putting into vaccination ourselves, it is not sufficient. So it's up to us to continue telling these stories, not giving up, and maintaining a sustained, let me call it campaign in quotes, to make sure that the policymakers know that we are on top of these stories and we are continuously looking at them. These stories for us have shown something very vital, that data informs, yes, but it's storytelling that mobilizes, it's storytelling that calls people into action. And we must continue to amplify what is at stake, and most importantly for us, what is possible. So this is a turning point for the country and for us who are in the fourth estate. Official development assistance, as we knew it, is no longer guaranteed, but that doesn't mean failure. For me, I see an opportunity. I see an opportunity for us to tell Africa's story from a solutions-oriented lens, holding governments and power to account, and not perpetuating what we call poverty porn, or the woye kind of reporting, so that we get help. I see an opportunity for us to take greater ownership in our storytelling, in the kind of role we play in the development of the country. I see an opportunity for us to reimagine health financing, and an opportunity for us as a media to lead, and not to follow, but to lead the path to resilient health systems. And that will only be done if we rethink and retell our stories differently, solutions-oriented. So for me, I just want to leave you with one thing, that we should not mourn the fading traditional aid as we know it as an opportunity. Let's embrace this moment, use it to look inward and build something more sustainable, more equitable, and more African, because Africa is our business. Thank you.
I don't know whether this one is working, because I wanted us to have a discussion. If you have any questions for Dr. Mercy Korir, and I think I will take the first question. If, for us here as journalists, if we were to report on the recent HIV drug, the twice a year, how can we report that, pivoting from your reflections today? How can we report that and still be able to hold power to account and reimagine this model that you're talking about?
Difficult one. So when lenacapavir was announced, Gilead was costing it at, was it 3 million Kenya shillings equivalent? And of course, when you think about that, I'm sure you'll be like, okay, let me just continue with the usual ARVs. For me, I would look at it as an opportunity. The biggest burden of HIV is in the African continent, South Africa being the leading. Is it possible with global partners, and this is a conversation that has happened even up at UNAIDS, for Africa to manufacture that medicine? Labor in Africa is way, way cheaper than if you compare with the West. Is it possible for us to manufacture it so that it's readily available? And with manufacturing, then it means there is long-term sustainability and a long-term assurance that the drug will be there. That's the first thing I would think about it from a sustainable point of view. The second bit is, of course, with every introduction of new medicine like that, from a business perspective, Gilead will be looking at recouping money, all the money they've spent many years of research and things like that. There's still philanthropic organizations and people who are willing to, bridge that gap. So could they bridge the gap so that that medicine is available in Africa? And what Dr. Gigi talked about is, at the end of the day, the West is looking at us, quote unquote, not transporting the disease there. So there are different ways to look at it, but at the end of the day is there a way to have this sustainably here? We're already manufacturing ARVs, so it wouldn't be something alien for us to manufacture that medicine there. That would be my thinking, but maybe Dr. Kwale has another view.
No, I like that thinking, but for me, it brings to question our actual policy development and implementation. I think we needed to ask a few more questions. Even as we adopt it, it is life-saving. However, what is the sustainability and what should we be looking for? Even if we say the next 2 years, this is it, but we must be very clear we're putting in systems that will move towards local manufacturing. So whenever policymakers are making that forward-looking is very, very critical. The other thing is just to continue monitoring its impact and potential any other side events. And then doing more research. Might we come with even an equally effective medicine, but locally from our products? Yeah.
Thank you, Dr. Ari. Any other questions for?
And as we get a question, the issue of local manufacturing, especially just looking at healthcare commodities, medicines, usually I think all governments always say we'll support local manufacturing, then as media we report government will support local manufacturing. Have we gone beyond that statement to ask, what does supporting local manufacturing mean? We have to think about it from a business. The pharmaceutical companies, last I checked, there were 35 pharmaceutical companies in Kenya that manufacture medicines. They're in business. So has government assured them of a market? And we are talking about here. They manufacture here, but government and other players import. So the policy probably should shift towards making sure that hospitals in Kenya use locally manufactured medicines. There are those that are not locally manufactured, but diabetes, hypertension medicines, and if you check the locally manufactured medicines for a month's dose of diabetes would be like 500 shillings. But when we import, we are paying around 5,000, almost 10,000 shillings. So there's need for government to move beyond supporting local manufacturing and making sure that there are policies that, one, assure the local manufacturers of the market. Secondly is, how is that policy environment? The tax and the tax regime, the tax policies are changing year on year. As a business, if I'm not able to look and forecast over the next 5 years, then I'm hesitant to put in investment into anything, because if next year my taxes are going to go up and I'm not sure, then I'm not willing. So we need to ask, what is the tax policy and tax regime looking like for local manufacturers? And then, of course, the issue of energy is a whole other conversation, because if your energy costs are always changing every 14th day of the month, then it means I'm not assured, or I don't have a predictable business model. Then it discourages local manufacturing. Not health workforce, I'm used to being in health a lot, but the human resource is there. We are training people every day. We are training biomedical engineers, we're training engineers, like every other day people are graduating. So the workforce to work in these spaces are there. But those things that don't assure investors of money, then we'll just be talking about local manufacturing without actually moving it into action. And the onus is on us to move beyond those statements and actually look into what does it take, and is that actually happening?
Okay, thank you.
Thank you.
Questions for Dr. Akwale or Dr. Mercy? Any more questions?
Yes, there's a question.
Oh. Okay. As a health practitioner and journalist, where is the gap on effective communication of health issues in Kenya? Both parties often take a more reactive approach than proactive or preventive approach.
So I'm usually caught in between both worlds. So let me start from media side. Health is complex, even to those of us who are in health every day. It's a complex story to report, because there are very many things. Let me use SHA as an example. I see stories about we blaming SHA because hospitals don't have medicines. But if you think about it, it is not the responsibility of the Social Health Authority for medicines to be in the facility, because SHA is one component of the health system which is on health financing. So it's just about making sure there's that finance. It's somebody else's responsibility, on the other hand, to make sure that the medicines are there. But there is an interconnection, because if the money doesn't come, then somebody else doesn't have medicine. But what we've been told here, people are always procuring every day. So there has to be money somewhere for that procurement. So are we following up for procurement 10 years worth of mental health medicine, yet children don't have antibiotics? Are we asking those questions? Because if you had money to procure medicines for non-essential things, then it means you could have actually used that money to procure for essential stuff. So it's about understanding what each component of health plays in, what it does and how it relates to the other. So it's always complex. So for us as media, it's about understanding those different balls that are always in the air and how they are interconnected. So when we don't understand, then we report something else, and the power of the pen, the power of the microphone, that's what people go to. So what happens on this other end, then they react. And they say, gazeti ya kufunga nyama, this media, they don't know what they are reporting, and then they leave it at that. So we are always at loggerheads. So my thinking would be, one is media is to take time to understand some of these things. I know our newsrooms don't afford us that. You're here today, by the time you go back, you're expected to have a story that goes to the newspaper tomorrow or has gone online, you know, or go to the news. So you may not have enough time to think about things conclusively or completely and understand some of how they are interconnected. So it's up to us to understand that. And for the people on this other side, is to also understand that we live and breathe health every day. If you're in the health finance, some things are obvious to you. So it's to be patient, understanding, and explain things well before things have escalated and people are at loggerheads. It's just to take time and, you know, communicate. Like, for example, in this meeting, I was hoping, you know, the people invited from all of these other government arms would have been here, because then they would have taken time to explain some of these things very well, so that at the end of the day, there's no blame game. But the other thing, and we were discussing this with Dr. Kwale outside there, is we have a low trust society where nobody believes what the other one says. I don't have a solution for that, but I don't know what we'll do about it. But we have to start somewhere. And I think if we are consistently, as media, reporting objectively and the right thing, and having all the voices that Maxi talked about, the lived experiences, the policymakers and the influencers, then we start getting that trust that we once had, and we start getting it back from our audiences and from the society.
Okay, thank you very much.
Thank you very much.
Dr. Korir.
Thank you.
You can take your seat.